So let's take a look at some of the categories that you might find yourself falling into after you take that history. Now again, I would really welcome you guys to sit down and think long and hard before you rush through this history taking form, and that goes for any doctor's office. The first thing and the most important thing is to be extremely honest. Don't think that saying or withholding information in any way is either embarrassing or anything. You need to be extremely honest when you take the history of an injury. Without that, you are missing maybe some critical pieces that that the doctor needs to know, and I certainly will need to know to help you. One would be if you don't want to reveal that you have diabetes, and that'd be one of the critical things, is because diabetes really does affect somebody's ability to heal. And if you're not honest about having that, or maybe you're not even aware that you have that, that would be an important thing that you're sort of not revealing during that history taking session. So let's hope you've never gone to a doctor's office and been brought back into a room without taking a history before the doctor is going to look at you. It's super important. So I know that a lot of you guys are going straight to Google and putting in the part of your body that hurts, like low back, and you're going to get just a myriad of different therapeutic approaches. What I thought would be extremely important, though, to start the process here at Body Doc is to begin like we do in a doctor's office, taking a history of your problem. It's extremely important. And if you did, you'd probably be answering these questions here. Now, in school, we learn history taking sessions, and by the way, there's quite an art to a history taking session. A seasoned doctor that has had a lot of clinical experience will be able to ask the proper leading questions based on what you put on the intake form and really come to a much better, what they call a differential diagnosis, a lot faster than if they had less experience. Because you've seen things over and over again, you've seen the way people fill out those intake forms, and you've gathered some degree of background prior to that patient visit. But anyway, we all go forward with this OPQRST. And the O is really important, of course, because it's going to dovetail into the list that you see above this. And these are the type of probably outcomes or the type of category that you would fall into as a patient when you went to doctor's office. And the first, of course, is the O, and the O is onset. What is the onset? When did the problem begin? When did the pain that you are now going to see the doctor for begin? And it's extremely important. Now, the word acute is used to describe something that just happened recently, could have happened yesterday, could have happened maybe a couple of weeks ago. Anything beyond about a month or so would be considered an acute injury. And then we get into repetitive stress injuries, which are poorly defined. They could be acute, where you're just feeling it yesterday, but it's been building for a long period of time. That's a repetitive stress injury. So they come on sort of insidiously. So patients that have those RSIs are more difficult to put into the category. Hence, I have it in the middle between what we know is something that just happened or what we know is something that's been going on a long time, which is the chronic category. But we start with the onset. And the onset gives us an ability to already put you in one of these 6 categories that are up here. P is palliative or provocative. So which things feel good and which things hurt it. Also pretty important. You might find that the problem doesn't hurt you at all if you're not using that injured part. And we might find, so that's going to tell us that what's palliative would be rest. What's provocative would be the grabbing of the tennis racket for a tennis elbow, or the bending over at the waist if there's a low back pain. So those are the palliative provocative. Quality. Quality is going to be, generally speaking, into 2 broad categories. We've got dull and achy, but we might also have burning. We must have searing. People use all different adjectives to describe the quality of a pain. And sometimes they're very difficult to interpret, but most of the time when patients fill out my intake form, the quality of pains is going to be sort of a dull or an achy. The R is referral or radiation. Referral and radiation refers to an idea that a problem could be evident in one place but be felt in another. So for instance, a nerve root irritation quite often is a problem right here in my neck as the nerve is exiting my neck. But I might feel it down my arm into like a carpal tunnel pattern, which would be quite common. And you can rule this in and out by doing various orthopedic examinations, which we're going to talk about next. But the R, referral radiation, is an important variable in regards to trying to understand if this is a referral from an organ that's maybe a visceral organ, or from a nerve root that's now being felt in a distal area. Severity, that's a very simple one. Most doctors' offices, and we have been using this for quite a few years now, have used the VAS scale, Visual Analog Scale. This is a really important one because if you want to know if something's getting better or getting worse, you want to have some reference point for where it began. So most of the patients that come into my office will circle anywhere from 1 to 10. Sometimes people circle the whole thing. Sometimes people put a line through the whole thing. The interpretation of that VAS is important, but we do have to establish some beginning points. So outcome measures can't start with ambiguity. We've got to say, okay, today you came in and you told me that your pain is a 5. Well, if the next time that patient comes back for a visit and it's not a 4 or 3, I've not done anything. It could be I've gotten worse, and I certainly wouldn't want to do the same therapeutic approach because I've made the problem worse. But having an established outcome measure using the severity level is extremely important in your history-taking session. And the last and most important that I find really interesting is the temporal. The T is the temporal nature of pain. Why is that one important? Well, the word temporal meaning the timing of pain, really important. In the acute injury phase with a mechanism of injury, this temporal is really simple. It's like I didn't have the problem, I slipped and fell yesterday, I landed on my wrist, and now my wrist hurts. The temporal nature of that is it started yesterday, it wasn't hurting before I fell, and now it's hurting. Those are really simple, but a lot of temporal nature of pain actually comes out. So when I'm talking to patients about the temporal nature of pain, I'll say, well, have you had this in the past? Or have you noticed that you get this every time you do something? The temporal nature really gives us a lot of clues to whether or not I'm dealing with maybe osteoarthritis as opposed to rheumatoid arthritis. The periodicity of rheumatoid arthritis is something that I get to know people. So I'll often ask a few questions like, hey, have you had this throughout your life? Oh, I have. Okay. Do you notice there's a pattern of it where it's coming every February or you're getting it every few months? Oh, yes, I have. Oh, interesting. Okay, so now we really are honing in on the fact that this person might be having an autoimmune attack that's got some sort of periodicity to it. And the temporal nature of pain is very different than osteoarthritis, which is I've got some wear and tear on a joint line, and it only bothers me when I do a deep squat or a deep knee bend. So this is, I hope, helps you to start to understand the process of taking a history of your injury. It's really important that you do not go any further than starting with this base level thing. I'm going to have my own set of tools available for you on my website as well, and you can watch my YouTube videos.